looking at the long axis of the aorta, and we can see the celiac plexus coming off as the first branch of the abdominal aorta. The superior mesenteric artery runs off inferior to that and runs parallel to the inferior placed abdominal aorta. Mr. Rosenfeld has some area of fluid-filled stomach in the near field. Then we have the SMA, then we have the aorta, then we have the vertebral bodies. And viewing this in long axis, as we see from Dr. Adkins' hand, he has a grip on the probe with two fingers balancing himself, and he can walk down the abdominal aorta in a long axis. We can also interrogate the aorta in a transverse plane, turning it with a probe pointed to the patient's right. Imaging initially the left lobe of the liver, and then walking down, trying to visualize the vertebral body as a acoustic window. Always, if there is a problem, using more gel, trying to use pressure on the probe to displace bowel gas laterally. Use pressure on the probe to displace bowel gas laterally. Finding the vertebral body, which is going to be hyperechoic in the far field. Looking anterior to that, a circular shaped abdominal aorta will be on the right side of the image, the left side of the patient. The inferior vena cava will be to the left of that toward the leading edge. You may lose the image with some overlying bowel gas. But don't worry, just move the probe inferiorly and try to continue to track the aorta. It will bifurcate near the umbilicus and to the left and right common iliacs. The aorta, it will bifurcate near the umbilicus and to the left and right common iliacs. As we move more superiorly, we can track the abdominal aorta up toward some of the acoustic landmarks. The SMA will look like a bullseye sign. It will be anterior to the abdominal aorta. It has a layer of hyperechoic fat surrounding it. And at that point where you see the SMA, we have the splenic vein will come anterior to the SMA, join with the SMV, and turn into portal confluence. Can we go back to that? Right here. Portal confluence, and anterior to the portal confluence is the pancreas. And the pancreas sits in the second loop of the duodenum. If we go superior to that, we can actually see the celiac plexus. This has been termed the seagull sign. The celiac plexus will come off from the abdominal aorta and then branch off. There's a branch to the left, which is the splenic artery, and a branch to the right, which is the common hepatic artery. This appears like a seagull. You have to get the left lobe of the liver in the near field to visualize that. So here we see the celiac axis, it's the seagull sign. And as we move inferiorly, we see the SMA come into view as the bullseye sign. And then inferior from that, we keep moving the probe down past the bowel gas to the bifurcation. So the celiac, the SMA, and the bifurcation are three main views that we look at the abdominal aorta. And again, when you're having trouble visualizing, you can go to long axis and visualize the aorta in long axis. Making sure that you can rotate the probe and make it look like a tube all the way across, and then you can walk slide the probe superiorly. And walk, slide the probe superiorly, sweeping across, and you can see the abdominal aorta and the SMA that runs parallel to that. Of note, in this image, on the near field, we have the left lobe of the liver. We can see the middle hepatic vein. As we use this as a takeoff, after we've seen the aorta, we can look at the IVC, move that over toward the right side of the patient's body. We can see the IVC as it traverses through the caudate lobe. We can see the IVC as it traverses through the caudate lobe of the liver, going all the way to the right atrium. Some of the landmarks to try to locate the IVC are the caudate lobe, the ligament venosum, and the middle hepatic vein. Don't be fooled by transmitted pulsations. The IVC can have pulsations secondary to the abdominal aorta. But the IVC goes through the liver while the aorta will go traverse next to the liver. And Dr. Atkins is scanning, showing the IVC as it drains into the right atrium. So after we've ruled out that the patient does not have a AAA in both long and short, we've looked at the IVC as looking for its volume status.